Today we will be talking about how to more effectively screen for SARS-CoV-2 infected patients. In many parts of the world, shelter in place or lockdown has ended, and now testing for the virus becomes urgent. Remember, one infected person infects 2 to 2.7 individuals, and 40 to 60% of those that are infected are experiencing no symptoms. Epidemiologists have emphasized blanket testing of everyone to identify and isolate the asymptomatics in addition to symptomatic patients. As we will discuss later, experts no longer recommend this tactic because of high false positive rates. However, there is one key clinical manifestation of this disease, fever, that may prove to be helpful to more effectively target testing. In order to better appreciate this approach, let's first review the life cycle of the virus in human cells. Upon binding to the ACE2 receptor through its surface knobs, and within 10 minutes of binding to the surface, the virus is endocytosed and enters the cell cytoplasm. Viral RNA is quickly replicated using a viral-specific replicase. The replicated RNA strands are assembled in the cytoplasm as nuclear capsids. At the same time, positive viral RNA strands encode for the synthesis of viral surface proteins that are transcribed and assembled in the endoplasmic reticulum, ER. Included among those proteins is the S protein that forms the surface knobs. The nuclear capsids subsequently bind to the outer surface of the ER where the knob protein is added, and the virus is enclosed in a vesicle that subsequently undergoes exocytosis and is released into the extracellular fluid where it can infect adjacent cells and contaminate the saliva and sputum. This entire process takes approximately 10 hours, explaining the rapid early replication of the virus after exposure and its ability to quickly spread from person to person. When the virus binds to the outer surface of the human cell, it stimulates two toll-like receptors, TLR2 and TLR4, and these receptors signal danger to the cell and activate an inflammatory cascade. Replication of the foreign RNA stimulates internal toll-like receptors, TLR7 and TLR8, activating interferon production and also the inflammatory cascade. This coronavirus contains inhibitors that block the interferon response, an important mechanism that usually kills the virus. TLR2, 4, 7, and 8 all activate NF-kappa B, resulting in the production and release of multiple cytokines, including TNF-alpha, IL-1 beta, and IL-6. All three of these cytokines stimulate a rise in body temperature, resulting in fever. In looking at the symptoms associated with SARS-CoV-2 infection, it is no surprise that the most common symptom is fever, found in over 90% of the 1,099 patients reported in the March of 2020 issue of New England Journal from China. Understanding its importance in this disease, how should we define fever? It is usually defined as a temperature of 38 degrees centigrade or 100.4 Fahrenheit. Remember, this is only a median, and in reality, each of us has a different thermal set point when we are not infected. And this set point is raised when cytokines are released during an infection like COVID-19. This slide shows a comprehensive analysis of 36 studies of human body temperature in open forum infectious diseases that reveals that the normal body temperature taken orally varies from 36.2 to 37 degrees centigrade or 97.1 to 98.6 Fahrenheit. As shown in this graph, it also turns out that those over 60 normally have lower core temperatures than those under 60. Given these variations, should the definition of fever be a static number, or would a fixed change in body temperature prove to be more sensitive? Doesn't it make more sense to define fever as a rise of 1.5 degrees centigrade or 2.6 degrees Fahrenheit above the normal set point for each individual. It is highly likely that using this definition, even a higher percentage of SARS-CoV-2 infected patients would be defined as having fever. We have been teaching our medical students to use illness scripts to improve their pattern recognition. And one of the most important elements of the script is the key symptoms. And as previously shown in the bar graphs, fever is the most common symptom and sign of SARS-CoV-2 infection. Could we use this key clinical characteristic to improve our screening strategy? After creating an illness script, our students are encouraged to create a tiered differential to assess the pretest probability of different diagnostic possibilities. If a disease has all or most of the key elements in the illness script, this diagnosis is placed in Tier 1, being deemed to have a pretest probability of 67 to over 90%. If the disease possibility has some of the key elements of the illness script and no rejecting factors, it is placed in Tier 2, uncertain, 34 to 66%. And finally, if the possible diagnosis has only one key element of the illness script, it is placed in Tier 3, or unlikely, with a pretest probability varying from 33 to 1%. Now let's apply these principles to the diagnosis of asymptomatic SARS-CoV-2 infected individuals. In most areas of the world, the prevalence of COVID-19 is 2 to 5%. Therefore, these individuals would need to be placed in Tier 3. We know from Bayes' theorem that most tests will not be helpful for diagnosing diseases in this probability tier. Assuming a sensitivity of 85% and a specificity of 99.5% for the RTPCR test, and applying Bayes' theorem using a smartphone, and assuming a 2% pretest probability, this test will be of limited value. A positive test under these conditions would only represent a true positive of 77% of the time. In other words, 23% of positive tests would represent false positives, and these individuals would be isolated unnecessarily and would require additional unnecessary and labor-intensive contact tracing. How can we improve the value of this test? If we could monitor the population we want to screen for fever using the definitions described earlier, applying a tiered differential for individuals with fever in the setting of COVID-19 epidemic in the absence of an influenza outbreak, we can safely predict that 50% of those with fever are likely to have COVID-19. 45% of those who have fever are likely to have another viral illness. And I estimated that 4% could have a fever from a non-infectious cause, and 1% could have fever due to a bacterial infection, such as urinary tract infection, skin infection, or bacterial pneumonia. This places diagnosis of SARS-CoV-2 infection in Tier 2, and Bayes' theorem dictates that tests are most valuable for diagnosis in Tier 2. As shown in this image of the smartphone calculation, when we change the pretest probability from 2 to 50%, a positive test has a 99.4% probability of being a true positive. In other words, there would only be a 0.6 false positive rate. Now the PCR test becomes very valuable for differentiating those who are infected from those who are not. In conclusion, remembering that fever is the most common symptom found in COVID-19 disease, found in over 90% of patients, this symptom and sign can be used to move the pretest probability for this infection from 2%, if screening those who are asymptomatic, to 50%, improving the true positive rate for the RT-PCR test from 77 to 99.4%. This approach is far more cost-effective and less labor-intensive than blindly testing an entire population. Thank you.